Alright, so this is our 9th overall lecture, and the second lecture in our newest series on airspace and interstitial opacities. In this lecture, we're going to focus on the airspace opacity. Let us begin by refreshing memories as to what came before. In the prior lecture, I was trying to convey the idea that normal lungs on a chest X-ray should show nothing other than vessels and rarely a thin fissure. Other findings, various types of white stuff, have to be explained. We discussed that these come in two general categories: alveolar or airspace opacity, and then interstitial opacity. Again, we're going to be focusing primarily on the airspace opacities. In the prior lecture, we described the process of an airspace disease as a filling or flooding of the alveoli or the terminal airspaces. What actually does the flooding comes in four general categories: water, pus, blood, cells, or some combination of those. We also discussed that airspace opacity can look very similar on a chest radiograph, but can be caused by a variety of different things. Pneumonia, hemorrhage, cancer, etc. can all look very similar. The difference is going to be in the clinical context, which in many situations will be obvious. It's still very useful to have a list of things that can cause airspace or interstitial opacities. Now we're going to hit on pretty much all of these in individual talks. This one is going to focus primarily on pneumonia. Not all pneumonias are created equal. People often use the word lobar pneumonia to describe a pneumonia. I just did on the prior slide. This right here would sort of be a classic appearance for a lobar pneumonia. But lobar pneumonias do not have to involve the entire lobe. You can have pneumonias that have a non-segmental lobar appearance. Now I use the word non-segmental on purpose. If you're seeing white stuff that follows a strict segmental distribution, you might be thinking about a volume loss process, and we're going to talk about that. Atelectasis is the fancy word for that in a dedicated talk. So the typical features for a lobar pneumonia are homogeneous airspace opacity that has involvement of either the entire lobe or a non-segmental portion of the lobe. It's patchy. Sometimes you'll see an air bronchogram. Other times, depending on the particular organism, you can see expansion or swelling of the lobe, bulging of the fissure, and other infections can actually cavitate. We're going to discuss cavitary processes in the following lecture. If we take a closer look at what's actually going on here in that diseased lung, what we're going to see is that the alveoli have been filled. So this is our classic airspace or alveolar disease process. Now I want to contrast that with this situation here. This is a different kind of pneumonia. This is a bronchopneumonia. Now if we take a close look at what's actually going on in the situation of a bronchopneumonia, we'll see something slightly different. We will see some pus accumulating within the air sacs, but for the most part, the infection is predominating within the bronchi. Bronchopneumonias are tricky because they have a variety of different appearances. You can have a very mild bronchopneumonia, which just manifests as some peribronchial thickening and maybe a few tiny little nodules. When it becomes more severe, the nodular opacities will start to coalesce and look more like a lobar pneumonia, where we've got a confluent airspace opacity. Because the disease process is affecting the bronchioles, you can get mucus plugging, which will result in some volume loss or atelectasis. Let's take a look at a practical example. So in this case, what we're seeing is a homogeneous airspace opacity. The edges are sort of ill-defined, all those classic features that we discussed in the last lecture for an airspace opacity. On the lateral view, you may be able to appreciate some swelling or bulging of the process. This is one possible look for lobar pneumonia. I picked this case specifically for a particular theme, and I'm going to address it again at the very end of this lecture, and that's to show you that pneumonia sometimes can look like cancers, and cancers can sometimes look like pneumonias. And we'll talk about that again more towards the end. Here's another practical case. This time we've got a different look. This is more of an interstitial pattern. Take a closer look here and I'll prove it to you. Blow this up. And I hope you can see that instead of a confluent, cloudy, blob-like, cotton-like opacity like we had with our lobar pneumonia, we instead have some streaky lines and some scattered nodular opacities. So this is a very good look for bronchopneumonia. And like I mentioned before, this exists on a spectrum where this would be sort of moderate in severity, and something like this would be more severe, where we've got those same streaky opacities, but in addition to that, we've got areas that are starting to become more confluent. This would be a good example of a pretty severe bronchopneumonia. So side by side, brought back our mild to moderate bronchopneumonia here, and then this is a different example of a lobar pneumonia. This one looks less like a mass, but it still has those classic findings of an airspace opacity where it sort of looks like a cloud or cotton, and it's more confluent. And if you squint closely, you may be able to see a few air bronchograms. So those two cases had pretty obvious findings. There was definitely more going on than clear lungs, like we talked about on the first slide. Lungs are supposed to be clear, and it was pretty obvious in both cases that they weren't. Let's have a look at another case that perhaps is less obvious. So we'll pan around here and go through our normal searching pattern. See if there's anything here that bothers us. What about that right there? That doesn't look totally clear. Maybe it's nothing though, I'm not sure. Maybe we should look at the prior. Let's have a look at the prior. So when we compare that same area, blow this up and get a good look at it, you can see that on the current exam, there's a little bit of cloudiness there relative to the prior exam. That's new. This is a patient who has been having a cough and a fever, and sure enough, this was kind of a subtle pneumonia. The point of this case is to demonstrate that sometimes picking up a pneumonia isn't easy. So you may be thinking to yourself, man, some of these findings look like they can be kind of subtle, and it can be. They can be quite subtle. What can make your job easier is if you have some tools. So here's our toolbox. We'll put some tools in there. And now let me teach you how to use them. So let's talk about the first tool, the silhouette sign. So what does that mean? It's all about finding an interface or not finding an interface. So what is an interface? If we've got three things here, sort of lined up, and they're alternating in density, you can clearly see where one starts and the other one stops. That thing, that's an interface. We'd call that an interface. So why can you see an interface? And when can you not see an interface? So this is a situation where we've got things that are different right next to each other and they're touching, so we can see an interface. So that's one way you can see one. Another way you can see an interface is if things are separated a little bit, like that. Now you can clearly see where one starts and the other one stops, and then the next one starts and then it stops. That's very easy to see. That will also work if they're the same density. So if they're not touching each other, well, you can clearly see where one starts and one stops. So sort of as a summary here, you'll be able to see an interface when you've got things that are different densities and they're touching, or things that are not touching, regardless of the density, you'll see an interface. So when might you lose the interface? Well, we don't have an interface here, do we? And what do we have? We've got those same three things, but they're in the same density and they're touching each other. So this is the silhouette sign. It's when we lose those interfaces. Now, what does that have to do with chest radiography? Remember that the way things look on a radiograph is not orange and yellow. It's different shades of gray, right? And those shades of gray have to do with the different densities of what's being imaged through the x-rays, how many x-rays they're blocking. Well, if we look at our chest, we've got a lung and lungs and heart, and we've got pulmonary arteries and veins, and we've got some soft tissues of the abdomen. All of that stuff, except for the lungs, which are air, is all soft tissue density. So you can think of that pretty much all as the same thing. And of course the lungs are air, normal lungs, right? Normal air-filled lungs. You don't see anything except for a few vessels and a fissure. So you really are only dealing with two main types of contrast here, excluding the bones. We're not talking about bones here. Just the soft tissues are all soft tissue density, and the lungs are air density. So you know what else is soft tissue density? Pneumonias, or cancers, or hemorrhage, or all those things that we mentioned before that are in the differential for an airspace or an alveolar opacity. So just continuing to drill this point home here, different densities that are touching each other are going to create an interface, and we have them all over the place on a normal radiograph. So let's look at probably the most obvious example right here, where you've got air density next to soft tissue density, and you can clearly see that there's an interface there. Now let's look at this example here, where we've got two things that are the same density and they're touching. That's the scenario where we lose that interface, right? This is our silhouette sign. So same cartoon chest here, this time with a pneumonia right there at the right lung base, and you can see that we've lost that interface. We can't tell where one starts and stops, so it would be blurred. Let's do a practical example of this. So we've got a frontal chest x-ray, and right along that left heart border we've got some white stuff. We'll take a closer look at that. Let's blow this up, get rid of this magnifying glass so we can see a little bit better. And if we trace the border of the heart here, you can see that we lost a portion of that interface. We can't see that. This is the silhouette sign, and what we know is that we've got tissue density, soft tissue density. It's the same density as the heart, and it's touching that area of the heart, right? Because that's the two components we need for the silhouette. So knowing that, we can predict where that pneumonia is at, because it has to be touching the heart, right? So if we move this over, bring in our lateral, I can tell you it's going to be right up front, right next to the heart. I didn't need the lateral to do that. It had to be there. And this is a good time also to refresh memories that when you look at the heart on a lateral view, remember that it's supposed to be homogeneous all the way across from front to back. Now let's do another case So again, at the left hard border, we've got some white stuff, right? Right here. Well, let's have a closer look at that. Blow this up. Now let's trace the border again. This time we can pretty much trace the entire thing. So what does that tell us? Well, we're not getting that silhouette, right? We're not losing our interface. So one of our components is gone. Well, we know we do have something that's soft tissue density there, right? We see a white thing. So what's the other part? The other part's that it's not touching, right? So this is a way of using the silhouette sign again to localize this. So we know that it's not going to be right up next to the heart. It's going to be either in front of it or behind it. It can't really be in front of it. There's not really room in the chest. So in this situation, it has to be behind it. So there we go, right there. And this is another good opportunity to refresh memories about the lateral view. Remember, as we go from top to bottom, there should be an apparent decrease in density. Things appear to get a little bit darker. And if we don't see that, we see it getting lighter down there. That makes us think that there's something hiding back there, right? So this is the so-called spine sign. And we'll talk about that again here in a minute. So we touched on this briefly in the last case, that there's more to the silhouette sign than just finding stuff. It's also useful for localizing. So let's look at additional application here, not necessarily with the lungs, but in the hilum. So frontal radiograph, and we'll zoom up on the hilum here, and you may see that in the left hilar region there is a round mass. Let's turn this into a cartoon. So remember those pulmonary vessels I said, those are soft tissue density, right? So if we have a tumor that's also soft tissue density, and it's touching, we're going to lose that interface. Well, but if it's not touching, if it's either in front or behind, then we're going to have that interface. So let's go back to our radiograph here, and let's see if we can find some of those interfaces. So there's one there, right with the heart. There's another interface here with that pulmonary vessel. We can sort of trace the outline of the mass. So there's several interfaces there. And remember, if we've got different densities or they're not touching, then we have an interface, and we do have an interface. We know they're the same density though. All those soft tissue densities are the same. So what that tells us is they're not touching. So now we can use this to localize it. We'll bring in the CT scan, and I'll sort of outline some stuff here for you. There's the heart, there's that pulmonary vessel, and sure enough, there's our mass, and it is indeed not touching the hilar vessels. It's behind it. So this is helpful sometimes as a trick to localize masses in the hilum, and this is referred to as the hilum overlay sign. So we've got a tool, and all tools need specific jobs, right? The right tool for the right job. So the silhouette is used for two main things. For finding subtle stuff when there's a loss of the interface, either by a blurring of the heart border or blurring of the diaphragm, or it's used for localizing stuff when the interface is present. Now let's talk about a different tool, the spine sign. This is what we mentioned earlier before, but I just want to again show the utility of this. So we've got a lateral radiograph here, and maybe, at a glance it looks pretty normal. I want to draw your attention right here though, and we'll bring in a normal to help compare. So this is a normal. Notice how the spine is getting darker, at least it appears to get darker. That's normal. So as we go down, we're supposed to get darker, and if we don't, we should suspect that there's something going on back there. So taking a look at this same patient now with the frontal view, we can see that there's some airspace opacity there. So this was indeed a left lower lobe pneumonia, pretty subtle looking at the lateral view, unless you consciously think to yourself, man, I want that spine to get darker. And if it stays the same, then that's positive. All right, our last tool that we're going to talk about is the hard window. So I have a mantra every day when I get up to come in to read radiographs with regard to the chest. Every day my mantra is the same. Today I will look through the heart. So what does that mean? That means that I will do a hard window through the heart. Every time I do I'm interrogating a frontal radiograph, I do a hard window, like this. Every single time. I look right there and I try to look through the heart. You should be able to see through the heart. So let's sort of back this up before we windowed. I'll show you side to side. So that was the current exam. Now we'll look at the prior. We'll do a hard window on both of them. Now, look at the prior. See how you can see through the heart? That's normal. That's what it's supposed to look like. When you can't see through the heart like that, there's something behind it. It's a retrocardiac opacity. So bringing in the lateral views, we've got our prior and our current. And I just refresh your memory on something that we talked about in the lateral anatomy lecture, which is those triangles. Remember, here's our aorta, here's our trachea, we've got this retro-tracheal triangle here, and then down behind the heart, we've got this retrocardiac triangle. Remember, nothing's supposed to live there. That is no man's land. So if we go back to our prior and current exam, and we take a look in that retrocardiac triangle, sure enough, it was black before, and now it's got some white stuff in it. So that's our retrocardiac opacity, and that was a pneumonia. Now let's talk about some potential pitfalls. Not everything that looks the same is the same. There are several potential pitfalls with regard to calling or overcalling an airspace opacity on a chest radiograph. So some of these we've talked about before, and we'll start by reviewing those, and then I'm going to introduce a few new ones, and then we'll review. You may remember from one of our prior talks when I was discussing some of the pitfalls of interpreting an examination with a shallow breath, especially when you were comparing it to another exam. And I said that we've got normal airways here, and they branch smaller and smaller into segmental and subsegmental portions. And when the patient takes a shallow breath, that it cramps those subsegmental branches, and it can cause collapse in the smallest subsegmental portions, which manifests as some dirty white stuff. So a shallow inspiration can sometimes create the appearance of airspace opacity at the lung bases. Another pitfall that I mentioned was this idea of beam angulation artifact. Remember that the ideal scenario is to shoot the X-ray totally parallel to the chest, but when a patient is in the bed, they're often not totally lined up and supine. Sometimes they're sort of in the semi-erect, upright position. And when we're passing the beam through, in this scenario, it becomes difficult to get it totally lined up. So what ends up happening is, instead of getting it totally perpendicular with the chest, we end up with something like this. And that results in a blurring of the diaphragm. Remember, we said because we've got, this is sort of a review of the silhouette sign now, we've got an interface, two different densities, air and soft tissue, so it should be a sharp demarcation, perfectly sharp, like you can draw it with a pencil. And then here in the red box on the right, we're seeing it look blurry. And you may say, well, that's because I'm applying the silhouette sign and there's obscuration of that diaphragm, it's blurred. I think there's something there. Well, this is an off-angle artifact. And so you have to be careful when you're interpreting radiographs that were performed in the bedside, especially when they're supine. And this can happen on either hemidiaphragm. So now let's talk about some pitfalls specific to the lateral radiograph. Remember, I mentioned that ideal scenario is for the patient to have their arms over their head, but because of the typical patient population is very sick, it's not always possible. So sometimes what happens is the radiograph is performed with the patient's arm down, which can create a big shadow across the lateral radiograph, and we've got some increased density that could potentially confuse you, make you think that there was an airspace opacity there in the lung. It's actually just the increased density secondary to the arm. Another issue is this thing here, the cardiac incisura. Remember that I made a big deal, and I mentioned again in this lecture, that the heart should have a homogeneous contour, but we do occasionally get this thing here. And remember that we mentioned that this can have a variety of appearances. It can be big, like this. It can be medium-sized, like this. It can be small, like that one, or sometimes you don't see one at all. But that's not a pneumonia. Now let's move on to a few new potential pitfalls, things that we haven't talked about before. So here we have a radiograph. Now I'm going to compare this to the normal. Just bring in a totally normal radiograph, different patient. I want you to look at the right heart border on the normal. See how that sort of sticks out? It's real sharp. You could easily draw that with a pencil. So you can only draw that line if you're clearly able to identify the right heart border. What if it doesn't project beyond the thoracic vertebral body, or barely projects beyond it? This actually happens in a small percentage of patients, and when it does happen, the heart border often has a blurry appearance. So if the heart isn't projecting past the thoracic spine, you often don't get that sharp border. It doesn't mean that there's an airspace process there, it's just the way it will look. Here's another potential pitfall. That right heart border, again, looking pretty abnormal there. Let's have a look at the prior exam on this patient. This study is actually from 3 years ago, and you know what? It looks pretty similar. And I will tell you that that study from 3 years ago, that was just sort of a routine for a school physical. The patient had no symptoms at that time. So what is this? What's going on there? So when you see something like this, especially when it's at the right heart border, what you want to do is you want to look for a lateral. So let's bring in the lateral. And the thing you're going to look for specifically is the sternum. Look at that. That's not a normal contour for the sternum. This is one of those sternal deformities that I mentioned sort of in passing, and this is the one that's caved in, the excavatum. A depressed sternum can actually produce loss of the right heart border, and it's a known mimic for right middle lobe pneumonia. I say, like, well, why is that? Well, when you've got a depressed sternum like that, it pushes the heart posterior into the left, and it also creates a bunched up appearance of those soft tissues there in front of the chest wall, and those things together create the appearance of increased density, which is what mimics that right middle lobe pneumonia. Alright, so this is actually the normal study that I showed earlier when I was talking about that normal right heart border. This time I want to take a look at the left heart border. This is very subtle, but I'm going to use it to illustrate a point that it's always sort of there in one degree or another, but when this finding is present in a more extreme end of the spectrum, then it can create some problems. So the right heart border looking very sharp and normal, like we could draw it with a pencil. Left heart border also pretty sharp, except for this part down here. It sort of gets blurry down there, right? Like, okay, well, that's no big deal. What about this situation here? Now, let's take another look right there. It's blurrier, right? Sort of more extreme blurry. So what is that? What is going on there? So let's bring in some cross-sectional imaging and let's try to figure out what's going on here. So same patient, and if you look at that left heart border, you'll notice that there's this thing right here. Well, what is that? That is fat. Now, it's normal to have a little bit of fat around the heart. Some people have more of it than others. This can create a blurred appearance of the heart border, and it can blur either side of the heart border. It can blur the left heart border or the right heart border, or both. So in this situation, that's what's going on there. And if we take a look back at it here again, notice that it is like a decreased in density. Fat is less dense than soft tissue. So it's closer, it's blacker. It's almost as black as lung, but not quite. So here's another example. This time I want to direct your attention to the right side of the heart, here. And again, we've got a grayish density that is causing some blurring of the adjacent diaphragm. If we take a closer look here, bring in another CT, sure enough, that is some more fat around the heart that's causing that appearance. So as a quick review, not everything that looks the same is the same. On a lateral view, sometimes the arm or the scapula can increase the density, make you think that there's something going on. It's important to look out for that. There is that, in some people, a little bit of increased density there at the anterior portion of the heart. It can have a variety of different shapes, but the more of these you look at, the more you'll start to recognize that thing as not being a big deal. On the frontal view, a large amount of fat around the heart can blur the diaphragm or the heart border on either side. If the heart doesn't extend past the right border of the thoracic spine, you can sometimes see a blurred appearance of the heart border. If the study is performed in the bed, supine or semi-upright positioning, you can sometimes get a little bit of faint blurring of the right or the left hemidiaphragm, more commonly actually on the left than the right. And then the last situation here was if we've got blurring of the right heart border, and it seems to be persistent on multiple exams, regardless of whether or not the patient has any kind of pulmonary symptoms, it's a good idea to have a look at the lateral with specific attention to the sternum, because a sternal depression, deformity of the sternum, can create that fake out mimicking a right middle lobe pneumonia. So the last thing that I want to talk about was something that I mentioned very early on in our first case, where I showed the pneumonia that sort of looked like a cancer. And I want to bring up this vocabulary word here, consolidation. When you see white stuff on a chest x-ray, sometimes you get the urge, the strong urge, to give it a name. And white stuff doesn't sound like a word a medical professional would use. You want to use a smart sounding fancy medical word like consolidation. But I want to warn you against doing that, not to be like a word Nazi, but more along the lines of it's a potentially dangerous way to think about things. Technically, consolidation is a blanket term that refers to any process that lives in those terminal air sacs. So that can be water, blood, cells, or the turkey sandwich you just aspirated, whatever. Now, pneumonia is the most common thing, but it can be any number of different things, including the C word, cancer. So the reason I'm making such a big deal about this is because I want to encourage you to follow up your pneumonias. Radiologists call this the 6-week rule. When I see a pneumonia in anybody who could potentially have a lung cancer, and what I mean by that is, I don't do this in healthy 18-year-olds, but in somebody who's 50, especially someone who has a smoking history, I will always recommend that they come back in 6 weeks, and this is what I want to see. I want to see it go away. It should clear in 6 weeks. Pneumonia can sometimes be caused by a cancer. You can have partial obstruction of an airway that causes a lack of normal clearing, and because of that, you have a pneumonia. So just because you have a patient who has a cough and a fever and a chest x-ray that looks like a pneumonia, you're like, okay, he's got a pneumonia. Everything fits, pneumonia, it's pneumonia. It's still a good idea to do this 6-week follow-up to make sure that you're not missing the mass that's being hidden by the pneumonia. All right, I'm beating the dead horse, but it's just a good habit to get in, and you'd be surprised how often you can potentially find something and catch it early and improve outcomes for cancer. All right, so we're finished with this talk, and as I mentioned earlier, the next one is going to be about cavitation. Certain pneumonias can cavitate, and then certain other infections, the poster child being tuberculosis, can cavitate, and we're going to discuss that in more detail in our next talk.